Welcome to today's NCLEX RN review session, and this time we'll cover how to identify, respond to, and manage life-threatening complications in cancer patients. And today we'll talk about early recognition of oncology emergencies, including superior vena cava syndrome, tumor lysis syndrome, hypercalcemia, neutropenic fever, syndrome of inappropriate antidiuretic hormone, and spinal cord compression. We'll also talk about critical nursing interventions to stabilize patients, prevent complications, and collaborate with the healthcare team, and to prioritize assessments and clinical warning signs to enhance your ability to detect deterioration early, and to tackle patient and family education on recognizing symptoms, seeking timely medical care, and understanding treatment plans. And our goal is to strengthen your critical thinking and clinical judgment to ensure that you feel confident tackling NCLEX RN questions on oncology emergencies. So let's get started with the Q&A. Question 1. A 56-year-old female client is admitted to the oncology unit with symptoms suggestive of increased intracranial pressure, including headaches, nausea, vomiting, and confusion. The oncology nurse explains to the client and her caregivers that the most reliable method to diagnose ICP is one of the following options: A, epidural ICP monitoring; B, positron emission tomography PET with CT scan; C, labs to evaluate glucose and protein; D, bone marrow biopsy. The answer is letter A. When it comes to diagnosing increasing ICP, the most reliable method is direct monitoring of the pressure inside the skull. And epidural ICP monitoring is a minimally invasive technique that provides real-time measurements of the intracranial pressure. And this is often used in oncology patients who are at risk for brain-related complications like cerebral edema or brain metastasis. And the goal of ICP monitoring is to keep the pressure below 20 mmHg to prevent damage to the brain. And this method is the most accurate for diagnosing ICP because it gives you direct pressure readings, allowing the healthcare providers to adjust treatment quickly. And this is a very crucial part of managing patients who are experiencing neurological symptoms, especially with cancer history and possible metastasis. Now, what about options B, C, and D? So let's talk about letter B, positron emission tomography, and with CT scan. These two are helpful diagnostic tools for visualizing brain tumors and also detecting areas of metabolic activity in cancer, but they're not the most reliable method for diagnosing ICP. The PET scan can show brain changes or areas of concern, such as tumor involvement or inflammation, but it does not provide direct measurements of pressure inside the brain. Letter C is also incorrect. Labs to evaluate glucose and protein. This can be useful in diagnosing metabolic disturbances or maybe infections, or assessing cerebrospinal fluid for signs of meningitis or, let's say, leptomeningeal metastasis. However, the labs won't give us a direct reading of ICP. And the most important test for diagnosing ICP focuses on pressure measurement, and the labs like glucose and protein levels are not specific enough to diagnose elevation of the ICP. Letter D, bone marrow biopsy, is typically performed to evaluate for hematologic diseases like leukemia, maybe lymphoma, or metastatic cancer affecting the bone marrow, but it's not related to diagnosing ICP. And in this case, a bone marrow biopsy would not provide any information about the pressure inside the brain or the causes of neurological symptoms like headaches and confusion. So this is it's not going to be a relevant option. So I want you to focus on the key terms that are mentioned in the test question. Remember that the client is experiencing headaches, nausea, vomiting, and confusion, which all suggest a neurological issue. And since these manifestations are pointing towards ICP or toward ICP, your first instinct here should be to look for a method that directly assesses the pressure in the brain. And next to that, I want you to eliminate those unrelated options. And so when you see those other choices like bone marrow biopsy, which does not address brain pressure, you can quickly remove this. And similarly, the PET scans and the labs are helpful in diagnosing other conditions, but not ICP measurement. And so the gold standard in measuring ICP is to directly monitor the pressure in the side of the skull. And that's why epidural ICP monitoring is your best choice. 2. A client who received radiation therapy for lung cancer metastasis to the brain developed increased intracranial pressure is being transferred to the ICU for immediate management to lower the ICP. The nurse caring for this client should expect an order for which of the following interventions? Options: A, administration of systemic biotherapy agents; B, intubation and hyperventilation; C, radiation therapy to the head; D, injection of steroids into the cervical spine. The answer is letter B. So in this case, to lower the ICP, hyperventilation is the most effective method, and this works by inducing vasoconstriction, which can reduce the cerebral blood volume and consequently reducing the ICP. And in this case, the patient would likely need to be sedated and intubated for mechanical ventilation. And it aims for a partial pressure of carbon dioxide level between 26 and 30 mmHg. And the effects of hyperventilation are short-term, but it's an important step in immediate ICP management. Now let's take a look into options A, C, and D. Now for letter A, we know that biotherapy agents can be used in cancer treatment, but they are not a quick way to reduce ICP. The goal in this case is to decrease pressure inside the skull rapidly, and biotherapy is not effective for that purpose. Now the radiation in letter C, although radiation can shrink brain tumors, also brain radiation therapy would actually be contraindicated in this case since it is the cause of the client's increased ICP. And radiation to the head would not provide immediate relief for elevated ICP, and this may worsen the situation in some cases. Now, letter D, injection of steroids into the cervical spine. These are typically not used to manage ICP directly, even though this can help reduce the inflammation in some conditions, but they are not an effective or immediate treatment for lowering ICP in this case. So, your strategy in answering this question is to look for immediate intervention. And the question is focusing on rapid ICP reduction. Think about which intervention would have an immediate effect on the cerebral pressure. So, next to that, you have to eliminate those unrelated treatments. So, the radiation and CRS don't act quickly to reduce the ICP in this case, so you can safely eliminate those as well, and including the biotherapy, which is also unrelated to ICP management. 3. A 75-year-old male with suspected spinal cord compression is admitted to the oncology unit for further evaluation. The oncology nurse knows that the most appropriate diagnostic procedure to assess the extent of spinal cord involvement is which of the following? Options: A, positron emission tomography of the whole body; B, computerized tomography of the spine; C, magnetic resonance imaging of the entire spine; D, diagnostic radiology films of the thoracic spine. The answer here is letter C. To assess the spinal cord compression and to evaluate the extent of spinal metastasis, the magnetic resonance imaging of the entire spine is the gold standard. And this is preferred because it provides detailed images of the spinal cord and the surrounding tissues, and it also allows for detection of multiple metastasis sites that may be present. Now let's take a look into options A, B, and D. Now, We know that PET scans are useful for identifying areas of metastasis and are also sensitive to cancer, but they're not the best option for assessing spinal cord involvement specifically. Now, I want to emphasize here that MRI is more precise for visualizing the spinal cord and the surrounding structures, making it the preferred choice. Now, letter B, computerized tomography of the spine. The CT scan are sometimes used as an alternative to the MRI when it is unavailable or contraindicated, but this is less sensitive than the MRI for detecting spinal cord compression and metastasis. Even though this can provide good images of bone structure, but they're not as effective at evaluating the soft tissues such as the spinal cord itself. Letter D is also incorrect. Diagnostic radiology films of the thoracic spine. This can detect abnormalities and soft tissue masses, but this is also limited because this can only capture a portion of the spine, and this method can also miss those potential metastases in other areas of the spine. So this is going to be an unreliable diagnostic tool for this condition. So for this test question, I want you to look for the most specific test for the situation. So in the context of suspected spinal cord compression, the test that provides the most detailed and comprehensive view of the entire spine is the MRI. 4. A nurse in the oncology unit is caring for a male client with a diagnosis of right lung cancer. During assessment, the nurse observes prominent neck veins and facial swelling. Knowing the client's cancer history, the nurse recognizes that this client is at higher risk for which of the following conditions? Options: A, pulmonary embolism; B, superior vena cava syndrome; C, myocardial infarction; D, carotid artery plaque buildup. The answer is letter B. The client here is at risk for the superior vena cava syndrome, which is a condition that happens when the superior vena cava is obstructed because of tumors or maybe enlargement of the lymph nodes or maybe thrombosis. Now, the obstruction can lead to impairment of the venous return from the upper body, especially the head, the neck, the arms. And so this can result in venous distension and symptoms like facial swelling. There's going to be jugular venous distension. And in this case, the patient's lung cancer increases the risk of compression of the superior vena cava. Now, why A is incorrect? Well, we know that pulmonary embolism is a serious condition that can cause dyspnea, but it would not cause the facial swelling or the jugular vein distension seen in superior vena cava syndrome. And I want you to remember that PE is caused by the blockage in the pulmonary arteries, usually due to a migrating blood clot. Letter C is also incorrect. The myocardial infarction would present with chest pain. There's going to be shortness of breath and changes in vital signs, but it would not cause the jugular vein distension or facial swelling seen in this patient. Now let's look into letter D, carotid artery plaque buildup. Well, the buildup in the carotid arteries can increase the risk of stroke, but it will not cause the same venous congestion seen in a client with a superior vena cava syndrome. So for you to answer this question correctly, I want you to focus on the symptoms, and it's stated about facial swelling. There is distended neck veins. So these clues should point you to a venous return issue, which will also point to the superior vena cava syndrome rather than pulmonary embolism or heart attack. And next to that, I want you to eliminate those irrelevant options such as PE, myocardial infarctions, because these two do not match the signs that are being presented in the case, especially facial swelling, jugular vein distension. So I want you to think about the cancer connection and tie it with the SVC. 5. The oncology nurse is caring for a 74-year-old male with advanced prostate cancer who has been admitted to the hospital for disseminated intravascular coagulation. The nurse explains to the client and his family that DIC is most accurately described as which of the following? Options. A disorder of blood cell production linked to low hemoglobin levels. B, a widespread clotting disorder that results in the depletion of platelets and clotting factors. C, a localized clotting condition causing platelet and clotting factor consumption in one organ. D, a systemic condition that leads to the excessive production of platelets and coagulation factors. The answer is letter B, because DIC is a systemic condition where an underlying issue such as cancer can cause inappropriate activation of the body's clotting mechanism. And this will lead to a widespread formation of blood clots throughout the circulatory system, which can cause organ damage and failure. Now, the depletion of platelets and clotting factors due to the continued clot formation can lead to hemorrhage, bleeding, and also this is a key feature in the disseminated intravascular coagulation. Now, it's stated a disorder of blood cell production linked to low hemoglobin levels. This is a statement that represents anemia, not DIC. And we know that with anemia, this is reflecting insufficient hemoglobin, whereas the DIC involves issues with the clotting system. Letter C, you should eliminate this one as well because DIC is not a localized condition. The DIC can affect the entire body, not just one organ, and it causes widespread clot formation. Letter D, you should disregard this one as well because in DIC, there is excessive activation of the coagulation system, but this does not cause the overproduction of clotting factors or platelets. But instead, the system will use up all the available platelets and clotting factors, and this can lead to the depletion. So, for you to answer this question correctly, I want you to recall the process of DIC, wherein it's going to involve the overactivation of the clotting system. There is systemic clot formation and also bleeding. And the key concept is widespread clot formation, and there is overconsumption of the platelets and the coagulation factors. So I want you to eliminate those options that describe localized or unrelated conditions. 6. A client begins showing signs of anaphylaxis shortly after the second cycle of paclitaxel is started. The chemotherapy nurse promptly halts the infusion and prepares to administer which of the following medications known as the first-line treatment for anaphylaxis? Options. A, IV antibiotics. B, H2 receptor antagonists. C, epinephrine. D, inhaled alpha agonist. Your answer here should be letter C. This is the first-line pharmacologic treatment for anaphylaxis, which works by rapidly counteracting the life-threatening symptoms of an allergic reaction, such as airway constriction and hypotension. I want you to recall the manifestations of anaphylaxis. And so, letter A, IV antibiotics. These are used to treat infections, but not anaphylaxis. And again, anaphylaxis is an acute allergic reaction. It's not an infection that requires antibiotics. B, H2 receptor antagonists. One medication that represents this is the ranitidine. This can be used to treat symptoms of allergic reactions, but they're not the first line treatment for anaphylaxis. Okay, this can be used adjunctively with the epinephrine, but not the primary treatment. Now, letter D, inhaled alpha agonist. What is this? Well, this can be helpful in some respiratory issues, but these are not the primary treatment for anaphylaxis. So if we're talking about inhaled alpha agonist, like maybe albuterol, inhaled actually alpha agonist here. Yeah, this is not going to really treat the anaphylaxis here. This is going to help with the bronchospasms, but again, this is not the first line treatment. So I want you to focus on the key treatments, especially for anaphylaxis, which is a severe allergic reaction. So this will require immediate attention. So you need to choose that option that will implement a life-saving intervention, which is that epinephrine. 7. A client with a high tumor cell turnover, such as one diagnosed with leukemia, is at increased risk for tumor lysis syndrome following cytotoxic treatment. The oncology nurse understands that the most common test used to diagnose TLS is which of the following? Options: A, glucose; B, electrolytes; C, complete blood count; D, PT-INR. The answer here should be letter B, because the TLS occurs when the tumor cells are rapidly destroyed. It will release the contents into the bloodstream, which can lead to dangerous electrolyte imbalances. So I want you to recall that TLS can lead to hyperuricemia. There's going to be hyperkalemia, hyperphosphatemia, and hypocalcemia. And so electrolyte testing is the most critical method here in diagnosing the TLS, which can develop within hours of cancer treatment. And although newer targeted cancer therapies may also induce the TLS, the diagnosis is generally based on the electrolyte abnormalities, making this is the most test for detection. Now, letter A, glucose, is incorrect. We know that glucose levels are important in monitoring general metabolic status, but elevated glucose is not a key indicator of TLS or lowering of the glucose. Now, letter C, complete blood count, although this is something that you can use to detect any changes in the cell counts following cancer treatment, but it will not detect or help diagnose the TLS, which is identified through electrolyte disturbances. Now, the PT-INR and D is also incorrect. We know that these are tests to assess blood clotting function, but these two will not directly indicate TLS. And I want you to recall the TLS so you can answer this question carefully. So again, TLS primarily involves electrolyte imbalances due to the rapid breakdown of the tumor cells. So the correct test should be letter B. Again, I want you to remember the electrolyte disturbances that can occur are hyperuricemia, increased potassium, there's going to be increased phosphorus, and a decreased calcium. Number 8. The oncology nurse is aware that which of the following drugs would be suitable for managing hypercalcemia of malignancy in a client with compromised kidney function. Options: A, bevacizumab; B, denosumab; C, pembrolizumab; and D, infliximab. The answer here is letter B. And why is that? Well, the denosumab is a monoclonal antibody that inhibits bone resorption, and this is going to be effective for those patients with hypercalcemia of malignancy, especially those who cannot tolerate the bisphosphonates due to the renal insufficiency. So unlike the bisphosphonates, the denosumab is not cleared through the kidneys. So this option is safer to use in patients with renal impairment, and it can also be used in patients who do not respond to bisphosphonate treatment. Now, letter A, which is the bevacizumab, is a drug that is primarily used to treat metastatic cancers, but is not indicated for managing hypercalcemia of malignancy or renal insufficiency related complications. Now, letter C, pembrolizumab, is used in the treatment of cancers like melanoma, and this immune checkpoint inhibitor is not applicable for the treatment of hypercalcemia of malignancy. Letter D, infliximab, is a medication to treat autoimmune conditions such as rheumatoid arthritis, Crohn's disease and ulcerative colitis, but it has no role in managing hypercalcemia caused by the malignancy. Now, since our question is focusing about kidney function, the key clue in the question is renal insufficiency. So I want you to look for that treatment option that is not excreted through the kidneys, and that again is letter B. And I want you to eliminate those unrelated treatments such as bevacizumab or the pembrolizumab and the infliximab. Number 9. A 66-year-old female client who had chemotherapy 3 weeks ago has developed sepsis and has been admitted to the oncology unit. The nurse expects the following interventions to be ordered, except for which one? Options: A, administer broad-spectrum antibiotics within the first hour of presentation. B, delay fluid administration until the patient's fever subsides. C, provide vasopressor therapy as ordered to maintain a mean arterial pressure of 65 mmHg. And remove any infected intravenous lines. Now, I want you to read back into the question stem. It stated the nurse expects the following interventions to be ordered, except for which one? So our answer here is letter B, because sepsis requires immediate and aggressive treatment to stabilize the patient. And one of the key interventions is intravenous fluid resuscitation. And here, fluids should never be withheld, even in the presence of fever, as the body requires fluids to maintain adequate circulation and perfusion of the vital organs. Now, if you're going to delay fluid administration, this can worsen the hypotension and lead to organ dysfunction. Now, the other options here are all vital to the effective management of sepsis. So, other answers here, we have A, C, and D are actually appropriate treatment. However, in this question, we are looking for that inappropriate option. And so in a client that has developed a sepsis, we need to administer broad spectrum antibiotics within the first hour of presentation to target the infection quickly. We need to administer the vasopressor to support tissue perfusion, especially when the patient is hypotensive despite adequate fluid resuscitation. And letter D, we need to also remove those infected IV lines or central lines maybe, which are actually suspected to be the possible source of infection. And so this will reduce the risk of further complication. But then again, this question is asking for that inappropriate intervention. 10. While monitoring a client receiving a monoclonal antibody infusion, the oncology nurse should be aware of which of the following signs and symptoms of anaphylaxis. Options: A, fatigue. B, itching around the IV insertion site. C, urticaria. D, pain around the IV insertion site. The answer is letter C. Urticaria or hives is a common manifestation of anaphylaxis, which is a severe systemic allergic reaction that can happen during or after receiving monoclonal antibody infusion. And the anaphylaxis involves the release of the histamine and other inflammatory mediators. So this can lead to the development of the hives. There's going to be angioedema, swelling, difficulty breathing, and hypotension. So I want you to recognize that urticaria is critical. And this is a sign that the client is experiencing anaphylaxis. And so letter A, fatigue, which is an incorrect option. This is a common symptom experienced by cancer patients, especially those undergoing treatments such as chemo or immunotherapy. But fatigue is not specific to anaphylaxis. This is a general symptom associated with so many other medical conditions. Now, letter B, itching around the IV insertion site. Well, this might suggest a localized hypersensitivity reaction, maybe a mild allergic response to the infusion or the needle insertion itself. But this reaction is different from anaphylaxis, which typically affects multiple systems and includes symptoms like hives, angioedema and respiratory distress. So eliminate this one. Same thing with letter D. You can discard letter D because the pain around the IV insertion site may occur due to mechanical irritation or catheter placement or even a mild local allergic reaction. And again, localized reaction is not a sign of anaphylaxis. 11 rather. A client is scheduled to begin chemotherapy for lung cancer. A venous access device has been placed for the administration of chemotherapy medications. 3 days later, during a follow-up visit for the next chemotherapy session, the patient presents with difficulty breathing, pale, and warm skin. Vital signs are blood pressure 79/30, heart rate of 135, respirations of 30 CPM, temperature of 103 degrees Fahrenheit, and oxygen saturation of 84% on room air. The central line site shows signs of inflammation. After notifying the rapid response team, what should the nurse prioritize next? Options: A, start an IV line and administer normal saline. B, administer a prescribed fever-reducing medication. C, apply cold, wet compresses to the client's head. D, obtain a portable ECG monitor. Your answer here should be letter A. We have an issue about circulation. Look at the blood pressure. The patient is hypotensive. Respirations at 30 cycles per minute. Same thing with the tachycardia. These three actually reflect that the client is tanking. There is sepsis going on. And so the fluids should be the priority intervention because this will help increase the blood pressure. This will restore the circulatory volume and also enhance the oxygenation and delivery of oxygen to the body tissues. And so when you are starting the IV line, administering the saline, this is our first step in the resuscitation process. All right. Now, what about letter B? Administer a prescribed fever-reducing medication. This is important for comfort, but this is not the primary action in this emergency. And the patient's low blood pressure, the tachycardia alone, and the signs of sepsis indicate that there is a grave need for fluid resuscitation. And when you're just giving the maybe acetaminophen here, this can be given after you have done your letter A. Letter C, apply cold, wet compresses to the patient's head. This can be helpful in lowering the patient's fever and also can provide comfort, but it's not the most critical intervention here. You should prioritize in stabilizing the patient's hemodynamic status with fluid resuscitation. I want you to remember about the ABCs rule. Now we have letter D, obtain a portable ECG monitor. Well, this can monitor the client's cardiac status, especially due to the tachycardia and hypotension, but this is not going to act on the hypotension. All right, we need to restore the circulating fluid volume and also to make sure that we can maintain the hemodynamic stability. Number 12. A patient undergoing treatment for stage 4 lung cancer reports experiencing new back pain. What is the nurse's priority action? Option A, notify the healthcare provider about the new symptoms. B, instruct the patient on using relaxation techniques to manage the pain. C, assess the patient's leg strength and sensation. D, administer the prescribed PRN opioid for pain relief. The answer is letter C. It's because the patient's new onset back pain can indicate spinal cord compression, which is a very serious oncologic emergency that can happen when the tumor invades the epidural space. And your first step is to assess for the signs of spinal cord compression, such as changes in the client's leg strength and changes in their sensation, especially in the lower extremities. And this could indicate nerve damage. Now, once you have completed the assessment, then you can notify the healthcare provider and determine the appropriate interventions, because they're going to give you the appropriate prescriptions, right? Now, what about letter A? We know that notifying the healthcare provider is very critical, but assessing the patient's neurological status, such as the leg strength and sensation, must be your initial nursing action here, because this will provide you necessary information to guide further treatment, and this will also ensure the healthcare provider is informed of the potential urgency of the situation. Letter B is also incorrect. Although relaxation techniques can be helpful for managing the pain, the priority is to assess for spinal cord compression. So you need to first determine if the back pain is related to a serious neurological issue before implementing comfort measures such as relaxation techniques. Now, letter D, administration of prescribed PRN opioid for pain relief. Well, this may be appropriate once the nurse has already done assessing for the spinal cord compression and already did the confirmation that the pain is not related to a life-threatening complication. And pain relief can be provided, but your priority here is to rule out spinal cord compression to prevent further damage. So I want you to take note of the other options in the question. These are more of like interventions, while we have letter C as the assessment. This is to determine about the complication, which is spinal cord compression. Let's have number 13. Following the change of shift report on the oncology unit, which patient should the nurse prioritize for evaluation? Options. A client with xerostomia after receiving head and neck radiation. B, a client who has a platelet count of 82,000 per microliter post-chemotherapy. C, a client who is concerned about receiving their scheduled long-acting opioid. D, a client who is neutropenic and has a temperature of 100.5 degrees Fahrenheit, 38.1 degrees Celsius. Your answer here should be letter D, because this neutropenic patient, this fever is a serious concern due to the high risk of infection and the potential for sepsis. And I want you to remember that fever in this patient can quickly progress to a severe infection, and this requires immediate intervention. Now, the other patients that you are seeing in the options here require assessment, but will not require as much urgent action compared to our letter D. Now, what is in letter A? This is xerostomia. This is a common radiation side effect to the head and the neck area, right? And this can cause discomfort and can be managed. It can be easily managed, and it doesn't really pose an immediate risk compared to the fever in the neutropenic patient. Now, we have 82,000 per microliter platelet count in letter B. We know that this is low, but not critically low. And I want you to remember that spontaneous bleeding generally occurs when the platelet count is below 20,000. So this patient is not in immediate danger and does not require urgent attention compared to our letter D. Now, what about letter C? A client who is concerned about receiving their scheduled long-acting opioid. Well, this is important to address their pain, but this does not take priority over the risk of infection in a neutropenic patient with a fever. So, when you're assessing a client with lung cancer that has spread to the bones, it's very critical for you to recognize a sign of oncologic emergencies, such as life-threatening complications, such as this one. Okay. Now let's have number 14. A nurse is providing care for a client diagnosed with lung cancer that has metastasized to the bones. Which of the following symptoms should the nurse recognize as potential oncologic emergencies? Select all that apply. Options. A, increased serum calcium level of 15 milligrams per deciliter. B, persistent numbness and tingling in the lower limbs. C, notable swelling in the face upon waking up. D, body weight reduction of 20 pounds in a month. E, serum sodium concentration of 136, actually that is milliequivalents per deciliter, 136 milliequivalent per liter. And letter F, mildly reduced blood potassium level of 3.4 milligrams per deciliter. So this is a select all that apply question. So your options here should be options letters A, B, and C. We have hypercalcemia in letter A, and this is a common metabolic emergency in clients with bone metastasis. And when the cancer spreads to the bones, the osteoclast will break down the bone tissue, and this can release excess calcium into the bloodstream. And some tumors can also produce parathyroid hormone-related protein, which tricks the body into pulling even more calcium from the bones. And the high calcium levels can affect the muscles, the nerves, and the kidneys. It can lead to weakness. There's going to be easy fatigability. There's confusion, nausea, constipation, and increased urination. I want you to pay attention about polyuria and the development of kidney stones. Now, if the hypercalcemia progresses, this can cause cardiac arrhythmias, can also lead to seizures and coma, and this can also escalate so quickly. So you need to promptly treat this with IV fluids, especially normal saline solution, bolus, also includes bisphosphonates and possibly calcitonin to address the hypercalcemia. Now, letter B, this is numbness and tingling in the lower limbs. This is reflecting spinal cord compression, which is another neurological emergency caused by the tumor invading the bone or the vertebra. And the first red flags usually are back pain. There's going to be numbness. There's tingling in the legs. And if the compression worsens, it can lead to weakness. There's going to be loss of movement and paralysis. Again, this is another medical emergency because if you're delaying the treatment, this can result to permanent nerve damage. And the treatment for the complication in letter B involves high-dose corticosteroids to reduce the swelling. It will be followed by MRI confirmation and either radiation therapy or maybe surgical decompression. Now for letter C, notable swelling in the face upon waking up. This is reflecting superior vena cava syndrome, and this is a major, we know that superior vena cava is a major vein that returns blood from the upper body to the heart. And if a tumor grows near the superior vena cava, especially in a case of lung cancer or lymphoma, it partially or maybe can completely block the blood flow. And when the blood cannot drain properly, it will back up into the face, the neck, the upper chest. It can lead to swelling. There's going to be distended neck veins. There's going to be shortness of breath and sometimes a bluish discoloration of the skin. And so without treatment, the superior vena cava syndrome can progress to airway obstruction. It can lead to brain swelling and also cardiovascular collapse. So the emergency treatment for this includes administration of steroids. There's going to be radiation or stenting to open the vein. Now, the rest of the options here, such as D, E, F. So let's take a look into the weight loss of 20 pounds in a month. Well, weight loss in cancer is common due to the tumor-related inflammation. It can increase metabolism and also decrease the appetite. So this is associated with cancer cachexia, which is a condition where the body loses muscle and fat despite adequate nutrition. While weight loss is a major concern for long-term health, it's not an immediate medical emergency. Now, let's have letter E, serum sodium concentration of, this is supposedly 136 milliequivalents per liter. So 136 milliequivalent per liter. There's a typo there. So this is going to be within the range, safe range. And you're going to disregard that one. So there's no imbalance. Letter F, mildly reduced blood potassium level of 3.4 milligrams per DL. Another incorrect. This is another typo. This is supposed to be 3.4 milliequivalents per DL. And this is a slight hypokalemia. We know that potassium is essential for heart and muscle function, but a level such as this one will not, it's not really a life-threatening condition. And unlike severe hypokalemia, so for example, if it's as low as less than 2.5, this can lead to much more life-threatening arrhythmias. It can lead to muscle paralysis, but this level here is not a medical emergency. Now let's have number 15. A client diagnosed with lung cancer has developed syndrome of inappropriate antidiuretic hormone as a complication of the disease. The nurse expects the primary health care provider to prescribe which intervention. Select all that apply. A. Administer chemotherapy. B. Perform routine serum sodium monitoring. C. Encourage increased fluid consumption. D. Restrict dietary sodium intake. D. E. Initiate radiation therapy. We have F. Prescribed demeclocycline. Your answers here should be letters A, B, E, and F. So, the syndrome of inappropriate antidiuretic hormone is a frequent complication of certain cancers, particularly lung cancer, especially small cell carcinoma. And in this condition, the body produces excessive antidiuretic hormone. This can lead to increased water retention. There's delusional hyponatremia and potential fluid overload. So the goal of treatment is to correct the underlying cause and manage fluid electrolyte imbalances. So we have letter A, administer chemotherapy, and also letter E, initiate radiation therapy. And since the syndrome of inappropriate antidiuretic hormone is often triggered by tumor secretion of ADH, so shrinking the tumor with chemo and radiation can help regulate the ADH production, ultimately resolving the problem. Now, letter B is also correct because SIADH causes delusional hyponatremia, and frequent sodium checks are very critical to assess the severity of the imbalance, and this will also guide your treatment adjustments. Now, rapid sodium correction can be dangerous, so this is something that you need to keep in mind. Rapid sodium correction should be avoided here. So I want you to pay attention to the gradual correction of the sodium in this case. Now, what about letter F? This is demeclocycline. This is basically an antibiotic that has an off-label use for SIADH because it inhibits the kidney's response to the ADH. It can also promote water excretion. So this medication can also help counteract fluid retention, and it can improve sodium levels. Now, what about letter C and letter D? Encourage increased fluid consumption. Well, this option can actually worsen the SIADH because the primary issue in SIADH is excessive water retention. We don't want this, okay? So our intervention here is to restrict the intake of fluids. Now, letter D, restrict dietary sodium intake, is also incorrect because in SIADH, this can lead to low sodium levels, and if we are restricting the sodium, this can further cause hyponatremia. It can worsen these symptoms. A home health nurse is conducting a follow-up visit for a client recently discharged 3 days ago after completing treatment for non-Hodgkin's lymphoma. During the assessment, the nurse should be especially alert for signs of which potential complication. Options: A, hypercalcemia. B, syndrome of inappropriate antidiuretic hormone. C, tumor lysis syndrome. And D, disseminated intravascular coagulation. And so the answer here is letter C. Why is that? Tumor lysis syndrome is something that can happen after a chemotherapy or radiation for those aggressive cancers like non-Hodgkin's lymphoma. And the TLS is one of the most concerning complications to watch for. And this is something that can happen when there's a large number of cancer cells breaking down rapidly. This can release the potassium, the phosphate, the uric acid into the bloodstream. Now, if this is not managed properly, the TLS can lead to the life-threatening complications like kidney failure. It can lead to severe electrolyte imbalances and cardiac arrhythmias. Now, letter C, the tumor lysis syndrome, is something that can happen within the first few days after chemotherapy or, let's say, radiation. So the breakdown of the large number of the cancer cells can flood the bloodstream with those intracellular contents. So these will overwhelm the kidneys, and it can lead to the hyperkalemia. There is hyperphosphatemia, low calcium, and high uric acid levels. So what you're going to need to do here is to watch the client for muscle cramping, there's weakness, nausea, vomiting, irregular heartbeat, and decreased urinary output due to the acute kidney injury. Now, letter A, hypercalcemia. This is something that you will see in metastatic cancer, especially multiple myeloma, breast cancer, lung cancer. So you're not going to see hypercalcemia in TLS. Instead, you will see hypocalcemia because due to the high phosphorus that will bind with the calcium. And so you will not see hypercalcemia here. Now, letter B, syndrome of inappropriate antidiuretic hormone, is something that is can happen especially for those clients with lung cancer, especially small cell carcinoma. And the SIADH can lead to the water retention. There's also delusional hyponatremia, but this is not the primary concern after lymphoma treatment. Now we have letter D, disseminated intravascular coagulation. This is something that is more likely going to happen with sepsis or for those clients with leukemia, but not lymphoma. And the DIC can cause the widespread clotting, bleeding, but again, this is not a typical complication after lymphoma treatment. Let's have number 17. A client has an absolute neutrophil count of 450 per cubic millimeter, but the nurse's assessment does not reveal any obvious signs of infection. What should be the nurse's top priority when caring for this patient? Options: A, ensuring a clean and aseptic care environment. B, administering antibiotics as a preventive measure. C, practicing strict hand hygiene. D, providing a well-balanced, nutrient-rich diet. Your answer here should be letter C, because for a patient with severe neutropenia, which is less than 500 per cubic millimeter, this is your priority. We want infection prevention. And since neutropenic patients have a compromised immune system, even minor infections can quickly become life-threatening. And so the most effective way to prevent infection is meticulous hand hygiene. Now, letters A, B, and D are all incorrect. Let's take a look into letter A, ensuring a clean and aseptic care environment. We know that this can help reduce infection risk, and maintaining a completely sterile setting is unrealistic in most care areas. And the primary focus should be on preventing direct transmission of pathogens, which starts with the hand hygiene. Letter B, administering antibiotics as preventive measures. We know that antibiotics are typically not given preventively unless the patient has a confirmed or high-risk infection. And also, the overuse of antibiotics can lead to resistance and disrupt the normal flora. So this can increase the risk of secondary infections like C. diff. We don't want that as well. Letter D is also incorrect. We know that good nutrition supports immune function and overall recovery, but it does not directly prevent infection. I want to make sure that you understand that hand hygiene remains the most critical intervention in preventing infections. Alrighty, 18. While assessing with oral care for a client diagnosed with pancytopenia, which action by the nursing assistant would require immediate intervention by the nurse? Options: A, the NA applies fluoride toothpaste to the client's toothbrush. B, the NA instructs the client to rinse their mouth with saline after meals. C, the NA incorporates baking soda into the client's saline mouth rinse. D, the NA helps the client use dental floss after eating. The answer here is letter D. And why is that? Well, go back into the question stem. It stated pancytopenia. And so this means that a patient has a significant decrease in the red blood cells, significant decrease in the white blood cells, and decreased platelets. So this is going to put them at higher risk for anemia, infection, and bleeding. And using dental floss can easily cause gum or bleeding, irritation, and this can also increase the risk of infection since there is low white blood cells in their body. So instead of allowing them to do the flossing, you're going to make sure that the client uses soft bristled toothbrush and also to do gentle oral care. And you also need to educate the NA here on the bleeding precautions and to also educate them about safer alternatives for oral care. Now, the options A, B, and C are all incorrect options for this case, right? So we know that letter A is actually safe and beneficial. What we're looking in this test question is the nursing assistant's action that requires immediate intervention. And so we have letter A. This is actually going to help strengthen the enamel and it will prevent cavities. And letter B, this is also recommended for oral hygiene. We know that saline rinses can help keep the mouth clean, reduce bacteria, and soothe oral tissues. We also have letter C. Adding baking soda to saline rinses can also help prevent mucositis. It can also neutralize acidity and reduce bacterial growth. And so, for this test question, I want you to remember about what pancytopenia is. Again, there is a reduction in their white blood cell count, the thrombocytes, and the red blood cells. So, the flossing is quite an inappropriate intervention here. Okay, there is a high risk of allowing the gums to bleed and the possibility of introducing infection. 19. A 60-year-old client with acute lymphoblastic leukemia is receiving treatment for tumor lysis syndrome following chemotherapy. The nurse is evaluating the client's understanding of their care plan. Which statement by the client indicates a correct understanding of their treatment? Options: A, I should drink as little water as possible to avoid swelling from all the IV fluids. B, the IV calcium they're giving me will get rid of the extra potassium in my blood. C, the medication allopurinol will help lower the uric acid levels in my body. And D, I need to eat more bananas and spinach to keep my phosphate levels stable. Your answer here should be letter C. And why is that? Well, the tumor lysis syndrome is the metabolic emergency that is caused by the rapid tumor cell breakdown. Again, it can lead to hyperuricemia. There is hyperkalemia, hyperphosphatemia, and hypocalcemia. So your treatment should focus on hydration, uric acid reduction, and electrolyte management and monitoring. Now, we have letter C here, which mentions allopurinol. This is a drug that inhibits xanthine oxidase, which will prevent the formation of uric acid, which is a key metabolic abnormality in TLS due to the tumor cell breakdown. And this is a standard treatment to manage hyperuricemia, so making the statement accurate and reflective of proper patient understanding. Now, letter A. This is incorrect. because aggressive IV hydration, such as the administration of 2 to 3 liters of fluids per day, is the cornerstone of TLS treatment. In order to promote excretion of the uric acid, it will also allow excretion of potassium and phosphate, and also to prevent kidney injury. And patients with the TLS are also encouraged to maintain fluid intake as tolerated, not restrict, unless there's fluid overload, or maybe if there is a concern of renal failure or pre-existing renal failure, which is not really implied here. Now, letter B, this statement is incorrect because the IV calcium gluconate is used in the tumor lysis syndrome to treat symptomatic hypocalcemia. We don't want tetany, we don't want arrhythmias, and so we want to replenish the lost calcium in the body. And the calcium gluconate doesn't get rid of extra potassium in the body. No, it doesn't. So you're gonna easily remove this option. Letter D, I need to eat more bananas and spinach to keep my phosphate levels stable. Well, this is totally incorrect. We know that bananas and spinach are high in potassium and phosphorus, respectively. And so the patient with a TLS already have hyperkalemia, right? And there's also hyperphosphatemia. So you don't want to allow them having bananas or, let's say, spinach. You're going to restrict their intake of potassium and phosphorus in this case. Let's have number 20. A 55-year-old patient with high-grade non-Hodgkin lymphoma has recently begun chemotherapy. Within 48 hours of treatment initiation, the patient reports muscle cramps, tingling around the mouth, and numbness in the fingertips. The nurse reviews the patient's lab values. So we have potassium of 6.2 milliequivalents per liter, serum phosphate of 5.5 milligrams per deciliter, serum calcium of 7.4 milligrams per deciliter, uric acid of 9.5 milligrams per dl, and serum creatinine of 2.5 or 2.1 milligrams per dl. The nurse suspects tumor lysis syndrome. Which of the following interventions should the nurse anticipate? Select all that apply. Options: A, initiate intravenous hydration with normal saline. B, administer sodium polyestyrene sulfonate for hyperphosphatemia. C, prepare to administer IV calcium gluconate for symptomatic hypocalcemia. D, administer allopurinol to reduce uric acid levels. E, encourage a diet high in potassium and phosphorus. And F, monitor cardiac rhythm and serum electrolytes closely. The answers are options A, C, D, and F. Why letter A? Initiating intravenous hydration with normal saline. Well, I want you to remember that with TLS, we want aggressive IV hydration because this is going to promote renal clearance of the excess potassium, excess phosphorus, and excess uric acid. So this will reduce the risk of acute kidney injury. Letter C is also correct because we know that there is hypocalcemia in TLS. The reason for the hypocalcemia is because there is hyperphosphatemia, and this will bind to the calcium ions. And that's why there is depletion of the calcium in the body. And this client will be at risk for developing cardiac arrhythmias and tetany. And that's why we are going to administer calcium gluconate right away to treat the hypocalcemia. Letter D, administer allopurinol to reduce uric acid levels. Again, this is going to prevent uric acid buildup by inhibiting xanthine oxidase. And we have letter F, monitor cardiac rhythm and serum electrolyte levels closely. This can actually would be a very good intervention as well because, again, with the imbalances in the electrolytes such as hyperkalemia and hypocalcemia, this can lead to life-threatening arrhythmias. So you need to continuously monitor the client for the dysrhythmias or life-threatening arrhythmias. Now, why not letter B? Administer sodium polystyrene sulfonate for hyperphosphatemia. Well, the medication polystyrene or sodium polystyrene sulfonate is okay, but the indication is incorrect. It stated sodium polystyrene sulfonate for hyperphosphatemia. This is not targeting the imbalance. The Kyaxalate supposedly is used for hyperkalemia, not hyperphosphatemia. All right. And for this patient that has hyperphosphatemia, they're going to be given the phosphate binders such as sevelamer or restriction of dietary phosphate as well, or phosphorus rather. Now, letter E is also incorrect. Encourage a diet high in potassium and phosphorus. No, the patient already has hyperkalemia. There's also hyperphosphatemia. So we should be restricting those dietary sources. 21. A nurse is monitoring a client with acute leukemia who began chemotherapy 24 hours ago for signs of tumor lysis syndrome, an oncologic emergency. Which of the following findings should the nurse recognize as indicative of TLS? Options: A, hypotension, low serum potassium, and increased urine output. B, fever, hypercalcemia, and metabolic alkalosis. C, muscle cramps, peaked T waves on ECG, and decreased urine output. D, tachypnea, low serum uric acid, and hypernatremia. The answer is letter C. Again, remember about TLS? This results from the rapid breakdown of the tumor after chemo. So this can release intracellular contents into the bloodstream. Again, this can lead to hyperkalemia, hyperphosphatemia, hypocalcemia, and hyperuricemia. So with the hyperkalemia, this can lead to muscle cramping. There is muscle weakness. There's going to be cardiac changes. You will see that the client's EKG will show peaked T waves. There's that risk of arrhythmias now. Now, there's also hyperuricemia. The uric acid can precipitate in the renal tubules. This can cause acute kidney injury and decreased urine output. So the patient here is prone to developing oliguria. Now, aside from that, there's also hyperphosphatemia and hypocalcemia because phosphate release can bind to the calcium. It will contribute to muscle cramps, though hypocalcemia is not directly listed here. Now, so the incorrect options here is we have letters A, B, and D. Now let's take a look into letter A, hypotension, low serum potassium, and increased urine output. Well, again, the low serum potassium in letter A makes this option incorrect. And the increased urine output is also making this statement incorrect, as we know that there is decreased or oliguria in renal injury. All right, so eliminate letter A. And if you look into the hypotension in letter A, this may occur later on, but again, this is not the primary sign in TLS. Letter B, stated fever, hypercalcemia, and metabolic alkalosis. Take a look into the hypercalcemia here. Remember that there is hypocalcemia, right? So eliminate this one right away. And the metabolic acidosis is actually going to happen due to the renal dysfunction, not alkalosis. And also fever is not a hallmark manifestation in the TLS. Now we also have letter D, tachypnea, low serum uric acid, and hypernatremia. So when you look into this option, you are seeing low serum uric acid. This makes this option incorrect right away, so you can eliminate this one. And the sodium is typically low or normal in TLS, not elevated. And the tachypnea could be reflective of acidosis, but it isn't really specific to that TLS in this case scenario. So I want you to go back into the concept of what TLS is. Again, go back into the electrolyte imbalances. There's hyperkalemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. And if we are not addressing this problem right away, this can lead to kidney injury. The client will end up with oliguria and possibly will have permanent kidney damage. 22. A nurse is assessing a client with metastatic breast cancer who is at risk for hypercalcemia of malignancy. Which early clinical manifestation should alert the nurse to the development of this oncological emergency? Options: A, muscle cramps, bronchospasm, and positive Vostok sign. B, polyuria, nausea, and lethargy. C, cold intolerance, bradycardia, and weight gain. D, petechiae, hematuria, and prolonged bleeding time. Your answer here should be letter B. Again, going back into the hypercalcemia complication due to metastasis, this is a complication that can happen when the cancer, especially breast cancer or lung cancer or multiple myeloma, can lead to excessive calcium release into the bloodstream. And I want you to recall the early signs of hypercalcemia. There should be polyuria. And the reason for that is because of decreased renal concentrating ability of the kidneys from the high calcium levels. The client here will end up with massive volumes of urine output. They also will end up with the nausea, vomiting due to the slowing down of the gastrointestinal motility. And there's also lethargy and fatigue because of there is neuromuscular excitability, because the neuromuscular excitability is depressed in such a case of hypercalcemia. Now, if you're not going to treat this complication right away, this can progress to confusion, can lead to seizures, arrhythmias, and also coma. Now, what about letter A, muscle cramps, bronchospasm, and positive Vostok sign? Now, focus into the Vostok sign. This is a sign of the hypocalcemia, so you can eliminate this one right away. These are signs of hypocalcemia. And these three can happen whenever there is increased neuromuscular excitability, especially in low calcium states. Now look into letter C, cold intolerance, bradycardia, and weight gain. I want you to remember that these manifestations are more linked to hypothyroidism, not hypercalcemia. Letter D, petechiae, hematuria, prolonged bleeding time. These are possible manifestations of thrombocytopenia or any coagulation disorders, but not hypercalcemia, right? Again, I want you to remember that hypercalcemia can cause early neurological manifestation. It can lead to lethargy, confusion, renal issues. There's going to be polyuria, dehydration because of massive urinary output. And I want you to always assess the calcium levels in cancer patients having these type of signs. Number 23. A 72-year-old client with metastatic breast cancer arrives at the emergency department with severe confusion, muscle weakness, and nausea. The family reports that the client has been increasingly lethargic and unable to eat or drink for the past 2 days. Vital signs include blood pressure 98/60, heart rate 118, respirations 24, and an irregular cardiac rhythm. Lab results reveal a serum calcium level of 15.2 milligrams per DL. Which treatment should the nurse anticipate as the priority intervention for this oncological emergency? Options: A, IV normal saline and IV bisphosphonates. B, oral calcitriol and phosphate supplements. C, IV calcium gluconate and oral vitamin D. D, restriction of fluids and administration of loop diuretics. The answer is letter A. And why is that? Well, take a look into the calcium level of 15.2. Normally, it should be at 8.5 to 10.5, right? Milligrams per DL. So our client's value is super high. And with a serum calcium level this high, this is an emergency. This requires immediate intervention. And so the first line treatment is going to involve the administration of IV normal saline, bolus, and also the administration of IV bisphosphonates. So we know that with the hypercalcemia, remember that I said earlier in the previous test item that there's going to be massive fluid loss in hypercalcemia. So we need to make sure that our client is replaced with boluses of IV, especially normal saline. And this can also prevent the accumulation of calculi in the kidneys, right? And the IV bisphosphonates can also enhance it can also inhibit the bone resorption. So it will lower serum calcium levels within 48 hours. Again, the medication here can inhibit bone resorption. It will reverse the hypercalcemia. And other additional interventions aside from IV saline and bisphosphonates would be the administration of calcitonin IV for faster calcium reduction, but the effect is somewhat temporary, but it's not included in the option. Now, letter B, oral calcitriol and phosphate supplements. Well, we know that calcitriol can increase calcium absorption, and this will worsen the hypercalcemia. And phosphate supplements are generally avoided because of the risk of soft tissue calcification. So that's something that you should eliminate as well. Letter C, IV calcium gluconate and oral vitamin D. Remember that our patient is already hypercalcemic. And the calcium gluconate can worsen that, so eliminate that as well. And we know that vitamin D can enhance calcium absorption, so this is also contraindicated in this case scenario. Letter D, restriction of fluids and administration of loop diuretics. Well, look into the words here, restriction of fluids. This is not supposed to happen. We know that our patient is losing lots of body fluids because of the polyuria. And when you're restricting the fluids, this can lead to dehydration. It can also increase calciuria, right? Calcium stones in the kidneys, right? And even though you are seeing loop diuretics in option D, this is only done when there is adequate hydration to promote calcium excretion. So letter D is something that you can easily get rid of. All right. So I want you to recall the normal range of the serum calcium, which is 8.5 to 10.5 milligrams per DL. Again, we are talking about metastatic breast cancer leading to the hypercalcemia. All right. Let's have number 24. A 58-year-old female with a history of non-small cell lung cancer presents to the emergency department with complaints of progressive dyspnea, facial swelling, and distended neck veins. She reports that her symptoms worsen when she lies flat. Physical examination reveals upper extremity edema and prominent venous distension on the chest wall. The healthcare provider suspects superior vena cava syndrome. Which of the following is the priority nursing intervention? Options: A, administer intravenous corticosteroids and diuretics to reduce inflammation and fluid overload. B, prepare the patient for emergent radiation therapy to shrink the obstructing tumor. C, elevate the head of the bed and provide supplemental oxygen to alleviate respiratory distress. D, arrange for immediate surgical bypass of the obstructed SVC to restore blood flow. Your answer here should be letter C. We have an issue with the breathing and circulation. So I want you to remember that superior vena cava syndrome results from the obstruction of the SVC. This can lead to impaired venous return from the head, the neck, and upper extremities back to the heart. So the condition can manifest as dyspnea. There's facial and upper extremity swelling. There's going to be distension of neck veins. And the immediate management for this focuses on relieving symptoms and also ensuring adequate oxygenation. And so if you selected letter C, by elevating the head of the bed, this can decrease the venous pressure in the upper body. This will reduce the edema and respiratory distress. So this should be your first task. And also, supplemental oxygen can also address the hypoxia. It will improve patient comfort and oxygenation. So these two interventions are non-invasive, but are readily available, and this can provide prompt symptomatic treatment. Now, what about letter A? Administer intravenous corticosteroids and diuretics to reduce inflammation and fluid overload. We know that corticosteroids and diuretics may be used to manage inflammation and reduce venous pressure, but they are not the initial priority. The effectiveness in SVC, the effectiveness of these medications in SVC syndrome is not well established, and these do not really address the immediate respiratory compromise. Now, in letter B, this is also incorrect. Well, we know that radiotherapy or radiation therapy may be a definitive treatment for malignancy-induced SVC syndrome, but it does not provide immediate relief of the acute symptoms and also requires time to plan and administer. So in this case scenario, I want you to select something that will immediately support or to treat the underlying distress, especially respiratory distress. Letter D is also incorrect. We know that surgical intervention is typically reserved for cases where less invasive treatments have failed or are not feasible. So this one is not the initial priority in the emergency management of the SVC syndrome. Again, don't forget about the ABC in answering this question. Again, you need to elevate the head of the bed and also provide supplemental oxygen. These are immediate, effective interventions to reduce the venous pressure. 25. A nurse is reviewing the treatment options for a client diagnosed with superior vena cava syndrome due to a mediastinal tumor. The healthcare provider discusses the management plan, which includes both immediate interventions and definitive treatments. Based on the nurse's understanding, which of the following treatments are expected for this patient? Select all that apply. Options: A, administration of high-dose corticosteroids. B, emergent radiation therapy for malignancy-related SVC obstruction. C, immediate administration of IV thrombolytics. D, endovascular stenting of the superior vena cava. E, loop diuretics to decrease venous congestion. F, chemotherapy for chemosensitive tumors. The answers are letters A, B, D, and F. Why letter A? Corticosteroids here, especially high-dose corticosteroids, are often used when the SVC syndrome is caused by the lymphoma or other steroid-responsive tumors. And this is intended to reduce the inflammation and also to reduce the tumor size. Letter B is also correct. This is first-line treatment for malignancy-induced SVC syndrome in patients with non-small cell lung cancer or maybe lymphoma or other radiation-sensitive tumors. And this is also going to help shrink the tumor, compressing the superior vena cava. Letter D is also correct because the endovascular stenting is highly effective. It is a rapid treatment for the SVC syndrome, especially for those patients with severe symptoms, for those who already have stridor or respiratory distress. And this can also restore the venous patency regardless of whether the cause is malignancy or thrombosis. Now we have letter F as one of the correct answers. Chemotherapy is also important for treating the SVC syndrome caused by chemosensitive malignancies such as small cell lung cancer and also lymphoma. So this can also help reduce the tumor burden, and it will also alleviate the SVC obstruction over time. Now, what about letter C? Immediate administration of intravenous thrombolytics. Well, we are talking about, this is referring to alteplase or TPA, but these are only used if the SVC syndrome is caused by an acute thrombus, or let's say catheter-related thrombosis. So this is not routinely given for tumor-related SVC obstruction. And a CT scan or a venogram must confirm a thrombus before considering thrombolysis as well. Now we have letter E, loop diuretics to decrease venous congestion. We are talking about furosemide or Lasix, and this is not really a primary treatment for SVC syndrome, although this may provide a mild symptomatic relief by reducing intravascular volume, but this will not address the underlying obstruction and really not considered a standard treatment. And so when you're selecting treatments for the SVC syndrome, especially in this case, consider whether the intervention directly addresses the cause, whether it's malignancy, and whether it provides rapid relief. Okay, so that would be my clue to you. And so, great job today. We've covered key oncology emergencies, their early recognition, and also essential nursing interventions to ensure timely and effective patient care. And I want you to remember again that your ability to assess, also to prioritize and acting quickly can make the life-saving difference for your oncology patients. And I want you to keep practicing your critical thinking and clinical judgment, and you'll be well prepared for the NCLEX ARN questions on this topic. So thanks for joining today's session. Keep up the hard work and see you next time.